It is my distinct pleasure to introduce Marcy Bolster. She may not remember this, but I met her in the mid-90s when I was interviewing for a position at Medical University of South Carolina. I've known Marcy for a long time, and I was going through her CV. She went to Duke for undergraduate and medical school. And one of the reasons why I wanted her to come here, other than being a big deal in rheumatology, is because she did her residency here at EVMS. After completing a residency, she went to the Medical University of South Carolina, MUSC in Charleston, where she completed her fellowship and stayed on as faculty from 1993 to 2012, going up through the academic ranks to eventually being professor of medicine. She was also the program director, or the rheumatology fellowship program director. In 2012, she was recruited to Harvard and the Massachusetts General Hospital, and again, went through the ranks and is now professor of medicine and is the fellowship director at MGH. She's had many roles educationally and administrative at both MUSC and Harvard, and is nationally known as an osteoporosis and scleroderma person. She has been very active in the American College of Rheumatology and American Board of Internal Medicine, including or culminating as the Rheumatology Subspecialty Board Chair and the Rheumatology Board Exam Committee Chair. She's been a member of the ACGME, MKSAP Committee, ACR Board of Directors. Are you in line to be president of the ACR? No, she's not yet. She's been a reviewer for many journals. She's received teaching awards. She's been awarded the Distinguished Program Director Award from the American College of Rheumatology. Her clinical interests include scleroderma and obviously bone health. And she's going to present osteoporosis to us. Marcy?
Are we on? Can you hear me? Okay. Well, thank you to Dr. Boni. Thank you to Dr. Mustarat. Thank you to EVMS to invite me to give medical grand rounds. This is a different venue than we had when I was attending medical grand rounds. And it's really nice to be here. In choosing a topic, I thought I would try to find something that is cross-disciplinary and is also applicable to what we do in taking care of patients kind of every day. My disclosures are listed here. And I approached this presentation with 4 questions. Do I need to take calcium and vitamin D tablets? These are questions that my patients ask, and I'm hoping or thinking that yours might. What should I expect regarding the side effects from the medication you are recommending? When I start this medication, how long will I need to take it? And do I need to change my medication since I had a new fracture? Has anyone ever had a patient ask any of these questions? Has anyone had a patient ask all 4 of these questions? All right, so we're going to start with, do I need to take calcium and vitamin D tablets? And I think that my hope is that I can maybe dispel some myths that patients come prepared to discuss in their visits with you. And what I'll do is I'll use the evidence that helped me understand where I stood with answering these questions for patients. And I look back in the evidence, and a lot of it is actually very old, and I'll bring forward some of the newer evidence as well. In terms of why patients wonder if they should take calcium tablets, it relates to their concerns that it could relate to heart disease. And so starting with a large meta-analysis, this was published over 10 years ago. It's looked at postmenopausal women in randomized trials, so there's strength there. The patients had to be on calcium supplements of more than 500 milligrams a day. All of the trials had to have more than 100 patients, again, a strength. The age of the patients was over 40, and the trial duration had to be over a year, again, a strength for the meta-analysis. And the conclusion from this meta-analysis was that calcium supplements increase the risk of cardiovascular events. Well, that's what the patients are coming to tell us about and their concerns. But when the studies were adjudicated for MI as opposed to self-report, there was no significant difference seen. An Australian study, this was a prospective randomized study of calcium supplementation of 1,200 milligrams daily, almost 1,500 women. It was a 5-year study and had almost 5 years of follow-up. And calcium supplementation in this study was associated actually with reduced hospitalizations and mortality in those who had underlying atherosclerotic disease. Okay. This is also helpful to know that patients that have underlying heart disease were not at increased risk, maybe even decreased risk. And then I like this study too, because this is an NIH AARP diet and health study. So this is patients that included dietary calcium intake as well as supplementation. And it was a prospective study, mean follow-up of 12 years. So those are strengths of the study. Almost 400,000 patients and in an age range of 50 to 71. And they evaluated calcium intake by diet, supplements, and what they found was that the calcium supplementation was over 1,500 milligrams daily. So men taking supplements, about 51% of them were taking supplements. Men had an increased incidence of cardiovascular related disease deaths, but not stroke deaths. And women were without increased cardiovascular disease or stroke deaths. So for women, the calcium supplementation at this level of over 1,500 milligrams daily was not associated with heart disease or stroke related deaths. But for men with calcium intake, supplements plus diet of over 1,500 milligrams, there were increased cardiovascular disease deaths. But this is a very high level of calcium intake, and this is more than what we actually recommend to our patients. This shows you, I like the images, the pictures, and you can see where the arrow is the place where men are receiving between diet and supplement 1,500 milligrams or higher, and that's where the line crosses 1 to be associated with increased risk. Going on, a Swedish mammography study of over 60,000 women, very long duration, a median of 19 years of follow-up. There were higher death rates from cardiovascular disease in women taking over 1,400 milligrams of calcium. So again, this is higher than we necessarily recommend. And I think those are important points as you consider your patients and their calcium supplementation. So in this study, calcium doses in the 600 to 1,400 milligram dosing did not increase mortality or cardiovascular deaths. So what I've told you so far is that there may be some increased risk of cardiovascular disease and death in men or women, but it seems to relate to a higher than recommended dose of calcium. So this is a very recent study, and it is looking at the Women's Health Initiative, which was a 7-year study and was published many years ago, where that Women's Health Initiative was looking at calcium and incidence of MI or stroke. But the post hoc analysis was 22 years of follow-up. They didn't actually know what happened to people, what dose of calcium they were taking or not. But they did follow up at 22 years, and they found 6% increased cardiovascular disease mortality. There was a decrease in cancer mortality, but no change in cancer incidence. And this again is the image that shows you the increase in cardiovascular disease mortality, the decrease in cancer mortality, and then the no change in cancer incidence. But keep in mind, this is a 7-year intervention trial that had over 22 years of post hoc analysis without really knowing what was happening in the lives of these patients. So the observations could have been fraught with problems, and also their observations could have occurred even just by chance and due to multiple comparisons. So to kind of bring us back together on this statement of how to answer this question about, do I need to take calcium and vitamin D, at least the first part of the question, these are the recommendations by different societies and institutions. The Bone Health and Osteoporosis Foundation, International Osteoporosis, the endocrinologist, the Institute of Medicine. And so for women that are 51 and older, men who are 71 and older, the recommendation is 1,200 milligrams daily of calcium to be given in divided doses because the body can't absorb 1,200 milligrams at once. And you can see that this is still below the level where there was any level of concern from the other studies. And I try to encourage my patients to get as much calcium as they can from their diet. And so here are some good sources of calcium. Milk, almond milk is actually a great source. So those patients that like to have smoothies can get a good amount of calcium. And I generally tell them most foods have about 200 to 300 milligrams. So if you have 2 foods a day, then you only need 1 supplement. And the other part of the supplement thing for patients is to encourage them to look at the back of the bottle, because it'll tell you the serving size, and here it's 1 tablet, and that tells you how much vitamin D. But some of them that they get, particularly if they order them online, it might be 4 tablets is 300 milligrams. And so they need to be able to figure that out. Well, let's move on to vitamin D. Sunshine's a great way to get vitamin D, but honestly, with the use of sunscreen, the vitamin D amount from sun exposure is reduced. And so often we need to supplement patients for vitamin D. And good sources, dietary-wise, are listed, but if you were trying to target 800 to 1,000 international units a day, which is the Institute of Medicine recommendation, it can be hard to get that just through diet. So generally, patients need to take over-the-counter vitamin D tablets. And patients will come in and they'll say, I read in the newspaper that it is not important for me to take vitamin D supplements. And this stems from a New England Journal of Medicine article that was published a couple years ago, showing that there was not a change in incident fractures in patients that were taking vitamin D supplementation. But let's take a deeper dive into that. So the VITAL trial was vitamin D and or omega-3 fatty acids. And the study was designed to look at cancer and cardiovascular disease in men over 50, women over 55. So the subject recruitment had nothing to do with bone health. It didn't have to do with vitamin D insufficiency, low bone mass, or the presence of osteoporosis. But the primary endpoint of this ancillary study was looking at incident fractures, non-vertebral, and hip fractures. And what they found was there were over 25,000 participants, 50% were women. Take a step back and think about the patients that we see in trials for bone health. Usually it's far more than 50%. It's usually over 80%. So again, you can see the study wasn't really designed for this ancillary trial outcome. There were 1,991 incident fractures. The median follow-up was 5.3 years. That's pretty good. And looking at vitamin D versus placebo, there were no differences in total fractures, non-vertebral or hip fractures, which were the primary endpoints. So your patient says, I heard it isn't important to take vitamin D supplements because this New England Journal of Medicine article showed that it didn't reduce fractures. And it's true. Fractures were not prevented in healthy people who took vitamin D supplements. So maybe it's not important for healthy people to take vitamin D supplements, and that might be true. Very few people in this study had osteoporosis, and so we're really not able to draw conclusions about vitamin D supplementation and fractures in patients with osteoporosis based on this New England Journal article. And in fact, really virtually all studies that are looking at bone health management have, at baseline, all patients are taking calcium and vitamin D. So that's just part of the treatment. I tell patients that it's just part of your treatment. It's like an accessory to the treatment that you are now going to be prescribed, but it's an important part to the treatment. So the treatment recommendations do include calcium and vitamin D for patients to address their bone health. So the take-home points, and then maybe a pearl or two to add to the take-home points of what we've talked about, that calcium intake should be 1,200 milligrams daily in divided doses. Patients should get as much of it as they can from dietary sources. And here's a little pearl that patients will also ask, should I take calcium carbonate or calcium citrate? Well, calcium carbonate requires acid to be absorbed, so it's best taken with food. But in patients who are on medicines that lower acid, they won't absorb their calcium carbonate well, so they are recommended to take calcium citrate. So anyone on an H2 blocker or PPI should be on calcium citrate. And the vitamin D recommendations are for patients with osteopenia and osteoporosis, 800 to 1,000 international units daily. The goal, no matter what your lab says, our lab says 20 to 70 or something like that. The goal is over 30 nanograms per ml. And another pearl, there have been studies that looked at that high dose vitamin D, so the 50,000 international units of ergocalciferol weekly. There are some studies that show that patients that take very high doses, maybe 100,000 units a month or something like that as a single dose, had increased incidence of falls. And nobody really knows why, but it's also maybe just easier to put patients on a daily dose. I have found so many times patients take their weekly dose and they finish it at 12 weeks or 8 weeks and there's no transition, so then they just stop because the medicine runs out. So I find it, sometimes I'll put patients on 5,000 or 6,000 international units a day for a certain amount of time, and then I can back down once I get their vitamin D to be sufficient. Okay, the second question. What should I expect regarding side effects from the medication you are recommending? I mean, patients come to see me and they start the conversation with, I don't really want to take the medicine that my primary care doctor recommended to me because I'm worried about the side effects. And I look at them, I'm like, I know, that's why you're here. We're going to talk about all these side effects and try to figure out what's the best fit. So I think you're probably familiar with a lot of the side effects of these medications. And I do hope to maybe give you the evidence to support how we weigh the risks and the benefits of medicines in talking to your patients. So before diving into that, just to make sure we're all on the same playing field, the decision to treat should be for people with osteoporosis with a T-score less than or equal to -2.5, or for people who have osteopenia and a FRAX score that would recommend treatment, major osteoporotic fracture of greater than 20% likelihood or hip fracture greater than 3%. But the other important group of patients to consider, and we've worked actually really closely with our hospital medicine group on this, is that any patient who's had a hip or a vertebral fracture warrants treatment for osteoporosis. And so you might find on your hospital admission that the patient's chest x-ray when they get admitted for pneumonia shows a T8 vertebral fracture, and the patient says, I've not been in an accident, I didn't fall off a ladder, it was just an asymptomatic fracture. That actually warrants treatment for osteoporosis. Because and here's another pearl, about 2/3 of vertebral fractures are asymptomatic. So we find them, and that's a way to find those patients with osteoporosis that would benefit from treatment. Here are the treatment options, and I think you're probably familiar with these. And you can organize them into IV, oral. I chose to organize them into daily, weekly, monthly, quarterly, twice yearly, yearly. But the bottom line is that all patients need to have these things. Weight-bearing exercise doesn't mean lifting weights. It actually means being on your feet and exercising, fall prevention, risk factor modification. And then we already talked about the calcium and vitamin D aspect. Just to highlight, there are 2 that have black box warnings. And we'll talk a little bit more about that in a few minutes. I've listed for you the medication groupings and the kind of common side effects. And we're going to first focus on the bisphosphonates. You might have wondered if I left denosumab out. I did, because we're going to get to that a little bit later. There's this thing called the acute phase reaction, and just a few facts about that. It occurs in 30 to 50% of patients who get IV zoledronic acid, and that's a high percentage. Think about the medicines you prescribe for people. Most of them don't have a likelihood of a side effect of 30 to 50% of patients. But it's not an allergic reaction. So I usually start with telling people it's not an allergic reaction. It's reasonably likely patients could have this happen. And it feels like the flu. I tell people it feels like if you remember getting the shingles vaccine, or if you remember getting the COVID vaccine. Some people kind of felt that flu-like feeling for a few days afterwards. I tell people it starts within a day or two of the infusion and usually lasts a day or two. The evidence shows that 90% think that it's mild or moderate, and most people don't opt out of the next infusion because as a fact of truth, most people don't get the reaction after the first infusion. Very small percentage will report joint swelling, and here's a photo of a patient of mine who developed, actually it looked like RA. I use the same image when I'm giving talks on RA. And she had a polyarticular arthritis, and unfortunately she required high-dose prednisone to get through this adverse effect of the medicine, but this is very unusual. And you can see that the drop-off after the first year, very few patients get this side effect after the first year for the second or third years of infusions. Well, what about the oral agents? They also can get this acute phase reaction. It's usually less severe. It's very uncommon in patients. And interestingly, it doesn't mean they would get the same problem or have the same experience if they were to take IV zoledronic acid. So it's really not like an allergic reaction. Well, can this acute phase reaction be prevented? The recommendation is to give patients 650 milligrams of acetaminophen 45 minutes to an hour before the infusion. And then we did a study at MGH because we were looking at inpatient IV zoledronic acid in the post-fracture setting. And orthopedics was a little bit concerned that if patients develop fever, say a couple days after their surgery, that might prolong their length of stay. And in fact, it didn't to give patients IV zoledronic acid in the hospital. But what we found was that if we gave patients acetaminophen before the infusion and then every 6 hours for 3 days, they actually didn't. They had a reduced incidence of the acute phase response or reaction. So what we recommend is acetaminophen. We recommend this over NSAIDs. This is generally an older population who would be at risk for adverse effects related to NSAIDs. So acetaminophen would be more ideal. And I tell people to have a scheduled dose of it, at least for a day, to see, and if they're feeling okay, then they don't need to continue it. Well, then patients will say, well, what about that jaw problem? Right? They don't really know what the jaw problem might be, but it's a pretty bad jaw problem. So I'm going to give you some evidence, but we're going to start with even just a definition of what osteonecrosis of the jaw is. It's exposed necrotic bone. It's maxillofacial. It's defined as poorly healing over 8 weeks, and patients have not had radiation therapy. It was first reported in 2003, and it was in patients who are receiving IV bisphosphonates, zoledronic acid, or pamidronate for cancer. And there's a very nice review by Wu et al. Of the published literature in 2006. And this was 368 cases of ONJ. And interestingly, nearly all of the patients had been treated with IV bisphosphonates. Most of the patients were receiving IV bisphosphonates for cancer. And in those patients, most of them received higher doses than we use to treat patients with osteoporosis. So an update of the data from 2006 was much more recently in 2015, and there have been updates, I think, since then as well that we'll talk about. So the incidence in patients with osteoporosis is 1 in 10,000 to 1 in 100,000. I mean, that's kind of a large range, but the incidence in the normal population is 1 in 100,000, so not even on bisphosphonates. So it could be that it's about the same that it's in the normal population. It is highest risk with IV bisphosphonates. It's also been reported with oral bisphosphonates, denosumab, romosozumab, because those are all anti-resorptive agents. It tends to occur when there's poor blood supply or with invasive treatment to the jaw. And so the risk factors are IV bisphosphonates, needing surgery, implants, extractions, things that manipulate the jawbone, something like a root canal or a crown or fillings. Those are not thought to be putting patients at increased risk. So what we do is we encourage good dental hygiene and also encourage people to try to complete their dental work before they start these medicines. I had a patient come in Tuesday and tell me that she's continued her alendronate, and she's just completed her dental implant. I was like, that's awesome. How did you feel? How did you heal? And she said, I healed great. But she stopped the medicine around the time of the implant. But think about, the bisphosphonates are so avidly bound to bone for years that it's hard to know that stopping a medicine for a few months around the time of the implant had any impact. It makes all of us maybe feel a little bit better that we're doing the right thing, but it's hard to know that that actually makes a big difference. So it's better to just have people complete their dental work if they can before starting an anti-resorptive agent. This is a slide borrowed from a colleague, and it's just one of those funny things. It's somebody decided to compare the risks, and the comparative risk of having ONJ, which is in yellow, is about as frequent as as dying from a lightning strike in New Mexico. And it's far less frequent than fragility fractures. Well, with this jaw problem, I have now become a reader of the website with the American Dental Association, and I've also talked to lots of dentists. And the American Dental Association does acknowledge the severity, but also the rarity of ONJ, and denotes that the risk relates to higher dosages of bisphosphonates, particularly IV, particularly in patients who've been on it for longer than 2 years, and then also in people who have trauma, whether it could be infection, periodontitis, or wear dentures. But the ADA, this is purposefully in green, like the ADA website, because of the high risk of fragility fractures, the treatment outweighs this very rare risk of an adverse effect. And the next thing is patients will say, well, what about that thigh problem? And an atypical femoral fracture, has anyone seen a patient who's had an atypical femoral fracture? It's terrible. It's terrible. And it's a very serious problem, but it's helped to guide the way we treat our patients in terms of duration of therapy. And we're going to get to that in a few minutes. So just to define it, like we did with ONJ, an atypical femoral fracture is a fracture that occurs in the proximal third of the femoral shaft. It can occur in patients who have osteoporosis, even who have not been on bisphosphonates. And it's associated with prolonged use. It's not thought to be causative by prolonged use, but it's been associated with prolonged use of bisphosphonates. These happen with minimal or no trauma. I had a patient tell me that she turned to reach for a dishcloth in the kitchen and she heard a crack and then she fell. So no trauma and then she fell. So it wasn't the fall that caused the fracture. And they also can, more than 50% of them are bilateral. So if a patient has one on one side, they should always be screened for the potential of having a atypical femoral fracture on the other side. Here's the picture of what it looks like. They're terrible. The characteristic features are that it's a transverse fracture through the entire bone. You can see there's cortical thickening as an early sign, and there's medial beaking. And those are characteristic. Oh, interesting. That stayed there. Not sure what I did to do that. Okay. So that's very characteristic. And so when patients tell you that they come to see you and they have had a femur fracture, you need to look at the x-rays because it may or may not be associated in the read that this was in somebody taking a bisphosphonate. We've actually talked a little bit about all of this, but there was a study by Schilker and colleagues in 2011. It was published in the New England Journal. And this study showed that there was a decrease in risk for atypical femoral fracture by 70% per year after stopping the medicine. There have been other studies that have duplicated this information. And so the risk of it comes down fairly quickly. And you can see, this is a more recent study that shows for every atypical fracture, these are the number of fractures that are osteoporotic related that would be prevented. And that's astounding, to prevent 850 vertebral fractures. So it shows you how rare the atypical femoral fractures are, and particularly if we are judicious with our treatment and truncate people's therapy to be able to optimize their response to therapy and minimize their adverse effects. So our conversations need to be with patients about the potential benefits, which are huge and outweigh the albeit small risks of the medicines. And this is just to remind me that really the atypical femoral fractures have helped to carve out this thinking of the drug holiday. So this is an interesting picture. This is Aruba, January 2022. Yes, we were using telemedicine. And I had a telemedicine visit with one of my patients with RA. And at the beginning of my telemedicine visits, I say, "Are you in Massachusetts?" Because that's where I'm licensed to practice. And she said, "Oh, no, I'm actually in Aruba." And I was like, "Okay, well, we can't have this visit, but can you just show me where you are in Aruba? Because I'm in Boston and it's January." So this was, I took a screenshot of this is where she was. And we had to stop that visit and wait till she came to Boston. But it does remind me about drug holidays. All right, bisphosphonates. Are they good or bad? Yeah, I think they're good.
You need to update the slide.
I did. What are you? Why?
Oh, because there's a new Glenda.
Oh, yeah. The movie's great, isn't it? Yeah. Okay, I could do that. But we all recognize the good witch and the bad witch. And they are good. So the take-home points with maybe a few pearls, most patients actually tolerate the medications well. There is the adverse effect on the first infusion, but past that, most patients do tolerate zoledronic acid well. We can mitigate that adverse effect with the use of acetaminophen. The ONJ and atypical femoral fractures are rare, and the benefit of treating to prevent fractures far outweighs the risk of these adverse effects. Okay, our third question. When I start this medication, how long will I need to take it? This, I think, is really important. So anytime I'm starting a medication for bone health, I have the conversation with the patient about how long I expect they will be on it. And we have that conversation really just about every time I see them because they want to know that. And that's not true for when you treat somebody with their blood pressure medicine or when you treat somebody post-MI. They're going to be on those medicines lifelong. But this is different because these do have periodicity of when we use them. So here's a case. 68-year-old woman presents for a routine annual visit. She had a DEXA scan 2 to 3 years ago, and she thinks it showed a little bit of bone loss. No other health problems. She takes calcium and vitamin D twice daily. Her mother had a hip fragility fracture. You can see she's of small body stature. This is that patient's DEXA that was done a week before she saw you, and you can see that she has osteoporosis at the femoral neck. What do you recommend? How many people would recommend bisphosphonate? You're going to go with the good witch? Yes, they're first-line treatment. But now we're going to talk about, we've already talked about kind of the risks and benefits a little bit. Now we're going to talk about treatment duration. How long to treat? The FIT trial was a study that looked at alendronate versus placebo a long time ago. And the FLEX study extended that. And so this looked at the FIT trial was 5 years of alendronate that was versus placebo. Then they took the people that were on the 5 years of alendronate and they extended that to 5 more years. So they were alendronate 10, or they gave them placebo for 5 years. They were A5, P5. And at 10 years, for those patients that then got put on placebo, they actually maintained spine bone density reasonably well. The other areas had some loss in bone density, but not to the level of baseline. There was an increase in bone turnover if they were on placebo, but not back to the level of baseline. And what they found was that the patients that did not take alendronate in that next 5 years, or the people that got placebo, had more clinical vertebral fractures. So a clinical vertebral fracture is one that presents with pain. I already told you 2/3 of vertebral fractures actually are asymptomatic. But so this is looking for patients who are presenting with clinical vertebral fractures. And so the risk of vertebral fracture clinical presentation was reduced by an additional 5 years of alendronate. And so the decision to treat past 5 years with alendronate needs to be individualized, maybe for patients who are at particularly high risk of fracture and or at high risk of vertebral fracture. Well, the Horizon trial was the original trial that brought zoledronic acid to approval, and it was a 3-year trial. And then then there was a, similar to the FLEX study, zoledronic acid was taken out to 6 years. And so there were the people that got zoledronic acid for 3 and then got 3 years of placebo, or then got 3 more years of zoledronic acid. And they honestly saw similar results as the FLEX trial. Now this looks at the outcome of morphometric vertebral fractures, which means radiographic. So this is actually going to capture those patients who had an asymptomatic vertebral fracture. And they found that new morphometric fractures were lower in patients that got 6 years of zoledronic acid. So those at higher risk for vertebral fracture, maybe somebody that's had multiple vertebral fractures already, would be somebody who might benefit from 6 years of treatment. And that decision needs to be individualized. Not presented here, but I can tell you that they also looked at 9 years of zoledronic acid, and there was no advantage of 9 versus 6. So extending past 6 would be unusual without instituting a drug holiday or a change to another medicine. So to summarize the durations, 5 versus 10 years for alendronate. 10 years is an awfully long time on alendronate, we'll say. 3 versus 6 years for zoledronic acid. And then how do you individualize the duration of therapy? I think it really depends on what the patient's risk factors are, whether they've had a fragility fracture, whether they've had multiple fragility fractures, where they are with their bone density and T-scores, and any other comorbidities such as glucocorticoid use or aromatase inhibitors. And so this really drives us to consider the drug holiday in terms of the duration of treatment. And the next question is, once you've treated a patient, say for 3 years with IV zoledronic acid, and you put them on a drug holiday, how long does that last? And there are different ways to guide that. I mean, the worst way to guide that would be the patient comes in with a new fracture, and then you wish you had started them back on treatment like a year prior to that. But we can use bone turnover markers. We can use bone density by DEXA scans to help decide how long to leave somebody on a drug holiday. It's generally a couple years, and some patients it could be longer. During the drug holiday, they should continue with weight-bearing exercise, calcium and vitamin D, and maintaining their bone health. And again, the drug holiday duration itself is individualized to the patient. The things I monitor during a drug holiday include the patient's risk factors, any new medical problems, say somebody develops breast cancer and is on an aromatase inhibitor, their fall risk assessment, they might be somebody who develops Parkinson's or something where they're at more risk for falling, their DEXA, bone turnover, and then obviously new fracture. There's very little data to guide us in how long for the drug holiday. So again, this is a shared decision with the patient and looking at their risk factors and their bone density. And then when you consider to restart therapy, we talked about with being off bisphosphonates each year, there's a 70% decline in the risk for atypical femoral fracture. So that declines relatively quickly. You can consider estrogen or raloxifene, hormonal replacement therapy, or raloxifene in patients during a drug holiday, but these are also anti-resorptive therapies, and they may not be ideal for patients who are older. Denosumab has limitations because it's not something you can just stop. There are risks related to discontinuing denosumab. You could talk about an anabolic agent like teriparatide, abaloparatide, which are the PTH analogs. Those might be something to use during a drug holiday. So just to add a pearl, their anabolic effect seems to be blunted in people who have previously had an anti-resorptive agent. So it might make you feel better. That they're on something, they may not have the same response that you would expect had they not been on a bisphosphonate prior to that. And then how long is the next course? So we had, say, 3 years of IV zoledronic acid, and then we had 2-3 years of holiday. And then what about the next course? And the resumption of therapy should be based, so the duration of therapy after they restart therapy should be based on our usual treatment guidelines. So you then restart with maybe 3 years of zoledronic acid again. All right, so here is here's that same, well, that same patient didn't age, but she did take her alendronate. So she's 68, she's seen in scheduled follow-up, she has osteoporosis, she's otherwise healthy, she takes calcium and vitamin D, and she has just had 5 years of alendronate, and then she's been on a drug holiday for 2 years. And her DEXA scan now, 2 years into her drug holiday, shows a decline in bone density. She has not had any new fractures. She would like to know what you recommend since she's had a decline in bone density. Well, here's kind of that list of what would you do next. So I'll give you a second to think about what you might do. I will tell you that there's probably more than one correct answer. I would say anything but continue her drug holiday because she's had a significant decline in bone density. So to summarize the duration of therapy, how long to treat would be to consider 3 to 5 years versus 6 to 10 years of bisphosphonate therapy if somebody's at particularly high risk. You would individualize the decision for a drug holiday as long as they have stable bone density, no fractures, 5 years of alendronate. How long is the drug holiday? The things that I think are most helpful for determining duration of drug holiday would be if they've had a new fracture, which hopefully they don't, whether there's a decline in bone density, and then also taking into account how long the patient's been off therapy, 2 versus 3 versus, like if they're stable at 2 years, you might continue it. Then if they've been off for 4 years and they have a decline, they've really been off therapy for a significant amount of time. What medication after the drug holiday, there are lots of options, and how long to treat, consider the similar treatment duration that you used before. Now our last question is, do I need to change my medication since I had a new fracture? So this is a patient who, while on a medication, say comes in with a humerus fragility fracture. The things to consider, we know that bisphosphonates reduce fracture risk by up to 70%. This isn't 100%, so not all fractures will be prevented. I would consider when this fracture occurred in the treatment course. So if a patient starts on zoledronic acid and 3 months later has a fracture, they really just haven't had time for the zoledronic acid to have full efficacy. So I might not change the treatment course for that patient. I always assess adherence. When it's IV or sub-Q, you know when they're getting it because it's when they come to get it at the hospital. But in somebody on an oral agent, I actually ask patients, how do you take it? And they tell me how they take their alendronate. Sometimes they tell me they take it with their coffee. And of course, that's not the right answer. And so we straighten that out. They need to take it with water. And I just ask them, how often do you miss a dose? I don't even say like, do you ever miss a dose? Because they're going to tell you no. 50% of people on oral bisphosphonates are not taking them at 1 year. So I just assume that sometimes they miss doses. And sometimes I'll say, I don't know, once or twice. And I'll say like in a month. Yeah, maybe once or twice a month. Remember, it's like a once a week med. So they're missing it probably as much as they're taking it. So assessing adherence can be a really powerful part of your evaluation. Then I'll evaluate the patient also for secondary causes of bone loss if they fracture while they're on a medication. And here's my workup for the lab testing I do in patients who may have fractured while on treatment. I don't often find secondary causes, but it's definitely important to check because these are treatable things. Sometimes you'll find that they have hyperparathyroidism, so you can continue treating their osteoporosis, but until you treat their hyperparathyroidism, you won't make as much progress. So here's the patient, 71-year-old woman who comes in with a new humerus fragility fracture. She's been on alendronate for 2 years. First, I'm going to talk to her about how she takes her alendronate, how often she misses a dose. Might even use bone turnover markers in somebody on an oral bisphosphonate because they should really have suppression of bone turnover if they're taking their medicine. And if they say they're taking it and they're not taking it correctly or they're not absorbing it for some reason, then their bone turnover would be high. I would evaluate the patient for a secondary cause for bone loss. And then I would consider whether we need to change therapy. I mean, certainly if there's non-adherence, then we need to change therapy. But, these medicines don't prevent 100% of fractures. So sometimes the medicine that you've chosen is maybe the best medicine for various reasons. If they're non-adherent to an oral agent, then it makes sense to maybe give them IV zoledronic acid. Denosumab could be given, but you need to be very wary of that because it's so important for a patient to be adherent to their denosumab. And we'll talk about that in a moment. But if they say they are adherent and they've fractured despite therapy, then you could choose an anabolic agent, or you could choose a different mechanism of action like denosumab, or you could just make the decision with the patient, we're going to go ahead and continue with the same course of therapy. So if adherence is a concern, as I mentioned, denosumab could be a real concern. And the reason that is, and you're probably familiar with this, is that you can't just stop denosumab. When denosumab was stopped, it's been demonstrated that there's an increased risk of very rapid bone loss and increased risk of multiple vertebral fractures, and that would be horrible. I'll tell you a story. I had a patient with pancreatic cancer who was on denosumab, and she was on hospice. She had been treated and developed pancreatic cancer and then was on hospice. She'd been treated for osteoporosis, and on hospice, her daughter asked if we could just stop the denosumab. And actually I didn't, because if she had stopped denosumab and had multiple vertebral fractures, it would have been so miserable for her that I thought it was more important that she get 1 or maybe 2 more doses of the medication. So it is not appropriate for a drug holiday, which means that you can't stop it. It has to be followed by another anti-resorptive medicine like IV zoledronic acid. Every time I see a patient on denosumab, I reinforce to them, remember, it's really important that you come every 6 months for your injection because otherwise you could get multiple vertebral fractures. So we talk about that every single time I see them. So if you have a patient who fractures while on therapy, I would consider modifying the route of administration, consider a different mechanism of action, and I'd also consider the same regimen depending on the time they've been on it. So just to kind of summarize what we've talked about, discussing the role of calcium and vitamin D supplementation as part of treatment for bone health is really important. I try to optimize the amount of calcium patients get through diet. I think it's important to set expectations with the patient about the planned duration of therapy, weigh out the risks and the benefits with the patient, and then question whether medication change might be warranted if there is a fracture despite treatment. And I'll just end with, you may have your own resources to provide to patients. These are some resources that we use in terms of websites. And then there's the there's a book that we published out of Mass General. It was written for patients. It's question oriented by chapters. It's called Facing Osteoporosis. And it's a useful guide for patients. It was written by the contributors were all over the country, endocrine and rheumatology, and most chapters were paired with a psychiatrist. So there was the angle of how patients are thinking and what things are important to patients. So thanks so much for the invitation and for your attention. I'd be happy to answer any questions.
Yeah. Thank you. That was really excellent. I'm curious, you mentioned resistance training, but actually very heavy weightlifting has been shown to reverse even osteoporosis. And so I'm wondering why that's not part of the recommendation. It can be safely done, even in people as old as 90. And I, as someone who is at risk of osteoporosis, my grandmother was 4'6" when she died, having shrunk about 6 or 7 inches. So this is something I'm really interested in. And I think we should be spending a lot more time talking about weightlifting, especially with women.
I appreciate your point, and it's true. Weightlifting can be very impactful for improving bone density. And it's also, as you said, really important that it's done under supervision and safely, because the last thing you want is somebody leaning over to pick up their dumbbells and getting, a vertebral fracture. So I did not explicitly go into that, but your point is excellent. The other thing that can be really helpful for patients would be the start and stop kinds of exercises, like playing soccer, playing tennis, where there's kind of that, or jump rope, where there's that kind of impact and starts and stops. So there are lots of different types of exercises, weight and aerobic, that can be helpful. What I want my patients to all engage in is weight bearing, because that's simple and that's just being on their feet. If they want to have dumbbells, if they want to do other things, I think that's an important part of their management as well. Another thing I'll do is I'll refer patients to physical therapy, to an osteoporosis program, which I don't know if your hospital has, but it would be a wonderful thing to add, because what they work with patients on is not only the exercises that would be good for their balance and core strengthening, but they evaluate the patient. So you could probably send people to physical therapy for gait evaluation and balance, and that can also be instrumental. Thank you. Yeah.
Again, that was a wonderful clinical talk. What is your take on the New England article where they gave zoledronic acid once and looked at bone mineral density after 10 years, and the fracture rate decreased by about 50%?
I think it's intriguing. And I think that we need to consider whether we do need to continue to give zoledronic acid once a year. There have been several studies that have looked at how often zoledronic acid needs to be given. There's one that was every 18 months in postmenopausal women with osteopenia at the hip. Interestingly, when you look at that, some of them had vertebral fractures. So they actually had osteoporosis, but they had osteopenia at a hip. And so they got zoledronic acid every 18 months. So sometimes I do give people less frequent dosing. I might do that in a patient who is younger and has a very long runway of needing treatment for a long duration of lifespan. So I might, and if they don't have really low T-scores, I might give them zoledronic acid every 18 months. If somebody's had several rounds of it, or even 2 rounds of it, I might not give them every, once a year for 3 years. I would individualize it. I might give them 1 dose and then recheck their bone density, reassessing their fracture risk and comorbidities. What about you? What are your thoughts?
I'm more intrigued than you, but I don't know. But it seems if you can do, there was no difference in the giving it twice or giving it just once after 10 years. And it might be just so much easier in the fullness of time.
Yeah, I think we need to study it more, but I think it would be really, it would be wonderful if we could give it so much even less often. We know zoledronic acid is one of the longer, so the bisphosphonates bind to bone and inhibit osteoclast at the site of bone. So if they stick to bone for years, which we know zoledronic acid does, maybe we don't need to give it once a year. That just happens to be what the Horizon trial was. Yeah. Yes.
Welcome back to Norfolk, Dr. Bolster. That was a wonderful talk. I've got a question about the trabecular bone score and using that in conjunction with the DEXA scanning. Should we be doing that? Should we be referring our DEXA scans to facilities that mate those two together, that type of thing?
Yeah, so it's also something that I think we all need to learn more about and how to use it. We don't do trabecular bone scores at our institution. It sounds like you don't do them here. Yeah, I think that there's a lot to be added from what I read about it. And because, you know, sometimes the bone density is falsely higher than you expect in somebody that might have osteoarthritis, might have calcification of the aorta, might have ankylosing spondylitis. And so getting a better assessment of the trabecular bone and of the kind of bone microarchitecture could be more informative. I don't know what to say because it's not become kind of universal. So I think, again, it's something to continue to learn about, but I do think it offers some advantages. Yes.
Excellent. Quick question. Timing after fragility fractures, is that being the presenting symptom of their osteoporosis? Is there any literature out there and how quickly to start therapy? We were arguing about whether to start therapy in the hospital with their fragility fracture.
Sorry.
He says, heck no. I said, why not? So I think there's probably a delay. They follow up in the office and they and haw about risks and things, but I don't know if there's any literature out there looking at timing after a fragility fracture as far as initiating bisphosphonate therapy.
I love that question. So I think the sooner the better. And the reason that is that there's lots of evidence that patients are undertreated, that they don't get treatment after a fragility fracture, which is why I kind of mentioned that thing about vertebral fractures on the chest x-ray. But somebody who's had a hip fracture, they have a lot of comorbidities, they get discharged from the hospital, they go to rehab for a while, they finally see their PCP maybe 4 months later, and there are like 10 other things to take care of, and then the bone health kind of drops off. So I was involved with initiating a fracture liaison service at my hospital, and we see the patients in the hospital and start treatment in the hospital. And not every patient is appropriate for that, but that's the goal. Because that way you can say you give them zoledronic acid, they're good for a year. That gives them a year to figure out what they're going to do next or when, or maybe even longer than a year. But at least you've got them on therapy. And orthopedics and others have raised the concern that maybe an anti-resorptive contributes to poor bone healing or non-union, and the studies haven't shown that. And then, as I mentioned, we give zoledronic acid in the hospital. Hospitals were very averse to doing that because of cost, but now zoledronic acid is generic and the cost is really low and the benefit to society is huge. And so our orthopedic surgeons, you know, we talk to them about your patients might get fever. Would it lengthen their stay? And actually it did not change the length of stay, as I mentioned earlier. So there's really very little reason to not figure out a way to get patients started as soon as possible. Because the treatment rates, if you don't know, so you listening and talking today, you think, well, everybody that has a hip fracture gets treated. The treatment rates in the US are anywhere between 15 and 30%. Whereas people getting put on beta blocker post-MI, it's like over 90%. And it should be the same.
It's almost 1 p.m. Dr. Bolster is going to be with us for a few more minutes. So if you guys have questions, please walk over to the podium and she'll be happy to answer. Thank you so much, Dr. Bolster.